Okay, it's pheochromocytoma. Okay, these patients episodic. Can you hear me? Okay, sorry. These patients episodic headache, diaphoresis, tachycardia, palpitation, and anxiety symptom in the setting of new onset drug resistant hypertension and hyperglycemia. New onset drug resistant hypertension and hyperglycemia with normal BMI are consistent with diagnosis of the pheochromocytoma. Diagnosis of the pheochromocytoma. Signs and symptoms of the pheochromocytoma are caused by the catecholaminergic excess. However, only 50% patients with pheochromocytoma are symptomatic, and even in symptomatic individuals, the diagnosis is frequently missed due to intermittent nature of symptoms. Pheochromocytoma is most commonly diagnosed at age 30 to 50 and is associated with autosomal dominant disorder, von Hippel-Lindau syndrome, multiple endocrine neoplasia type 2, neurofibromatosis type 1, measurements of urinary and plasma fractionized metanephrine, and catecholamines are used to make the diagnosis. Physicians must have a high index of suspicion for pheochromocytoma, as it may be misdiagnosed as a psychiatric disorder in otherwise asymptomatic patients. Next. Okay, it's a normal stress response. I don't think that if we have done it for the first time, it would have corrected. Okay. Okay, this patient's symptoms in response to his stressful work situation mood appears low, poor sleep, fatigue, and are consistent with a normal stress response. His symptoms are mild rather than excessive. Given the nature of the stressor, he does not meet the full criteria for any disorder. He is not markedly distressed and does not himself bring the subjects up with the physician. Most importantly, the physician exhibits no impairment of social and occupational functioning. A key feature, a key feature of a key feature of psychiatric illness on the psychiatric illness from this patient continues to function well, still performs at work, enjoys socializing and leisure activities. Next. Is it bipo on past week like he has manic episode? Yes, and along with psychosis. Schizophrenia without a manic, like schizoaffective. Okay, you give first. It is not like it is in between A and E. It is not totally schizophrenia because it takes more than 6 months, and there are other symptoms like too, like negative mood. Yes, but he is in manic state now, truly, and it is not a delusion. It's not a brief psychotic. I always get confused with brief psychotic. What does it mean? Eh, Okay, okay. And how we can get the schizoaffective? What is the rule of getting the diagnosis of schizoaffective? Okay, schizoaffective mood problem. Yes, with depression. Okay, Maybe you were right. Yes. Okay, I'm wrong. So I need to understand the schizoaffective. The term is very complicated in psychiatry. Okay. So your way of picking the schizoaffective is like some features of schizophrenia along with a mood disorder or manic problem. Like schizophrenia plus mood or manic. Sorry. Okay. Okay. That's wonderful. Okay. Which is there any sequence which comes first or which comes second? Okay. Okay. Schizophrenia from. Okay, we will come. Okay. Schizoaffective disorder. Start with the box. Major depressive or manic episode. Major depressive or manic episode concurrent with symptoms of schizophrenia. Major depressive or manic episode concurrent with symptoms of schizophrenia. Lifetime history of delusion or hallucination. Lifetime history of delusion or hallucination for in the absence of more than 2 weeks in the absence of major depressive or manic episode. And mood episodes are prominent and recur thought throughout illness. Mood episodes are prominent and recur throughout the illness and not due to substance or other medical condition. Okay, so these patients' clinical presentation and history are consistent with the diagnosis of schizoaffective disorder. Schizoaffective disorder bipolar type. Schizoaffective disorder bipolar type. He currently exhibits symptoms of manic episodes, decreased need for sleep, grandiose delusion, loud, pressure speech. He also meets DSM-5 criterion A for schizophrenia for schizophrenia 2 or more than two of the following: delusion, hallucination, disorganized speech, grossly disorganized behavior, and negative symptoms. His history indicates periods of persistent hallucination for more than 2 weeks in the absence of major depressive or manic episode when his mood is stable. Schizoaffective Schizoaffective can be differentiated from schizophrenia and bipolar. Schizoaffective can be differentiated from schizophrenia and bipolar disorder by assessing the relationship of mood and psychotic symptoms over the course of illness. Over the course of illness, if mood symptoms occur in schizophrenia, they are typically present for a small portion of the illness. In contrast, the patient's mood symptoms appear to be present for a significant portion of his illness, making schizophrenia less likely. Okay, so this is another thing. If the mood symptoms present for a significant portion, then it is not schizophrenia. It is schizoaffective disorder. In bipolar 1 psychotic symptom occur exclusively during during manic or depressive episode. The persistent of hallucination when the patient's mood is stable. On the persistent of hallucination when the patient's mood is stable rules out the bipolar 1 diagnosis. Okay, this is very high yield. Yes, yes. Okay. He's looking for new medication for his treatment. So you are finding intellect, like you are finding new knowledge. So what does what is your answer? Okay, intellectualization and rationalization. Intellectualization is focusing on non-emotional aspects, like look at the box. Focusing on non-emotional aspect to avoid distressing feeling, and rationalization like justifying behavior to avoid difficult justifying behavior to avoid difficult truth. Intellectualization, think about in that way, like somebody has like GI cancer, and he's looking for advanced chemotherapy, he is looking for immunotherapy, like it is not day-to-day practice, but he is looking for the newest therapy, like in GI cancer they are you may know that in GI cancer trastuzumab like immunotherapy is given if HER2 is positive. So it is like an intellectualization. He is looking for newest therapy which is not used in day-to-day practice. So this is intellectualization. And rationalization, like like if somebody has GI cancer and you are in a dilemma, chemo first or surgery first. So you are consulting with a surgeon and along with an oncologist, and then you rationalize that which one is better, like which one has greater outcome. Like if you give adjuvant chemotherapy, it has better outcome along with the surgery, and if you don't go with the adjuvant one, then it has some chance of having metastasis. So that's how you can rationalize your information. I don't know my rationalization is correct or not, but I tried in my way. Okay, if you just get the answer, that is all right. Okay, psychological defense mechanism. I am reading now explanation. Psychological defense mechanism are unconscious means of responding and adapting to emotional stressor that serve to decrease anxiety and provide a sense of security or control. The patient is primarily employing intellectualization, a defense mechanism that allows him to avoid anxiety by focusing on the non-emotional aspects of his cancer diagnosis. His decision working is to keep working serves as an intellectual focus as he spends hours a day analyzing that results and researching experiment therapies rather than confronting the painful emotion associating with poor prognosis. His over reliance on intellectualization interferes his ability to deal with his feelings and grieve with his family. Okay. Okay. Hyperactivity and impulsivity are non-specific feature that may be due to ADHD, and another cause ineffective parenting personality traits when symptoms are frequent and cause impairment and present across multiple settings, school, home, and physician's office. ADHD, for which effective medication exists, norepinephrine reuptake inhibitor, atomoxetine stimulants, methylphenidate, and alpha-2-adrenergic agonist, clonidine, should be considered. Parents consider when, when parents describe, when parents describes a child's disobedience as limited to home setting, problems specific to parent-child relationship should be suspected. In this situation, where the father has tried unsuccessfully to manage by using a self-help book, promote management training is the treatment of choice and provides an effective intervention for his daughter's inappropriate behavior. Okay. He has mild hand tremor, sweaty palms, isn't the features of the thyroid, like treatable things comes first, then the non-treatable. And hydroxyzine, I think that promethazine, hydroxyzine, first generation antihistamine. I think that thyroid, because what will what we will do with the chemistry. Okay, I'm very poor in chemistry too. Okay. The patient's anxiety, sleep disturbance, weight loss, and tremor, sweating, and increased heart rate are consistent with hyperthyroidism. The patient, the patient first step, the patient first step in evaluating, the patient first step in evaluating hyperthyroidism is measurement of serum TSH, which is low in patients with primary hyperthyroidism. Many different disorders cause hyperthyroidism, most commonly grave disease, and diagnosis of underlying etiology is necessary for appropriate treatment. Differentiating hyperthyroidism for anxiety disorder can be difficult to overlap in symptoms, anxiety, insomnia, sweating, palpitation, and some causes of hyperthyroidism, postpartum and painless thyroiditis can present with minimal or no thyroid enlargement on examination, making it more challenging to diagnose thyroid disease. Signs and symptoms associated with thyroid dysfunction rather than an anxiety disorder include unintentional unexplained weight loss, as in this patient, new onset atrial fibrillation, hypertension, lead lag, menstrual changes. To avoid misdiagnosis and inappropriate treatment, it is important to assess thyroid functioning in patients with new onset anxiety symptoms and associated physical symptoms. Next. Okay. Low levels of 5-hydroxyindolacetic acid. Low levels of 5-hydroxyindolacetic acid is are associated with suicidal behavior. 5-hydroxyindolacetic acid is the primary metabolite of serotonin, which is most important neurotransmitter responsible for modulating modulating mood and behavior. Low levels of CSF 5 hydroxyindolacetic acid are thought to represent the dysfunction in serotonin syndrome. Serotonin is the target of a selective serotonin reuptake inhibitor, the class of medication considered for first-line depressive. So these patients have several important risk factors for suicide, including suicide attempts, the strong predictor of future suicide behavior, and a history of psychiatric illness. Other risk factors for suicide include the presence of medical illness, concerning substance use, and family suicide. Okay, next. Is it performance anxiety, panic? Like he has only problem in doing interviews. Okay, it's sad. Social anxiety disorder, and I am sad. Okay, this patient has performance anxiety, which is classified in DSM-5 as social anxiety disorder. Performance only, social anxiety disorder, performance only. Individuals with performance only social anxiety disorder do not fear non-performance social situations, are not socially avoided in general. The pharmacological treatment of the performance-only social anxiety disorder includes as need beta blocker or benzodiazepine rather than maintenance medication. Beta blocker or as needed basis help control the associated autonomic response, tremor, tachycardia, and diaphoresis due to their addictive potential. Benzodiazepines are avoided. Benzodiazepines are generally avoided in patients with personal or family of the substance use disorder. In addition, they are preferred when performance could be impaired by sedation and cognition side effect, giving presentation as in this case. Cognitive behavioral therapy is an effective non-pharmacological approach. Next. This elderly patient, this elderly patient with no psychiatric history uh, now has uh, now has symptoms suggestive of mania, impulsive overspending, abruptly quitting job, and elevated mood, insomnia, pressure speech, new onset behavioral changes in older patient, new onset behavioral changes in older patient with no psychiatric history should prompt consideration of medical and substance induced related causes. The patient recently started taking ropinirole, a dopamine agonist medication used for RLS that has the affinity for D2 and D3 receptor. Treatment with dopamine agonist, even at therapeutic doses, increases the risk of impulse control disorder that may present with manic like signs and symptoms. In the absence of history of impulse control, in the absence of a history of impulse control problems, manic or depressive episodes, or medical condition known to cause mania, this patient is most likely experiencing dopamine agonist induced impulse control disorder. Other impulsive behavior that may occur with dopamine agonist therapy include pathological gambling, compulsive shopping and eating, and hypersexuality. The first line treatment is to discontinue the offending medication ropinirole and the patient's mental monitor the patient's mental status. Medication induced behavioral changes are usually reversible and resolve quickly once the medication is stopped. Okay. Sorry. Yes, he is depressed. Okay, so this patient has, and in depression, like we have found a question in depression, who the patient who has suicidal tendency, we will get increased 5 hydroxyindolacetic acid. And normally 5 hydroxyindolacetic acid for what? Pheochromocytoma? I don't remember. Or 5 hydroxyindolacetic acid, or it is serotonin syndrome. Serotonin, I don't remember. There is another thing where we will get increase. Okay, sorry. Okay, this patient has several findings concerning for depression, including hopelessness. Patients with depression frequently have somatic presentation and may have difficulty describing their emotion. Further assessment of depression, including a careful screen for suicidal ideation, is the most appropriate next step in the patient's evaluation, particularly given her multiple risk factors for suicide, chronic pain, recent job loss, self-medication with substances, and isolation. Inquiring about suicidality allows the determination of an appropriate and safe treatment setting, hospitalization if the patient is actively suicidal. This patient should be asked if she has wished for death and has thought of killing herself. If the answer is yes, additional questions should be asked regarding methods, plans, and intent to act on that plan. Okay.
Right.
Okay, it is corticosteroid induced psychosis. So these patients exhibits. So these patients exhibits the acute onset psychosis. This patient exhibits acute onset psychosis that is temporarily associated with the introduction of a new medication, most likely a high dose glucocorticoid. Most likely due to a high dose glucocorticoid for asthma exacerbation, his psychosis does not appear to be associated with delirium. He is alert and oriented and or any other psychiatric or medical illness. High dose glucocorticoids is given for allergic, inflammatory, and autoimmune conditions. May cause glucocorticoid-induced psychosis, an example of medication-induced psychotic disorder. Psychotic symptoms typically occur during the first week of glucocorticoids in treatment, but can occur at any time. Glucocorticoid can cause manic or depressive symptoms. Okay. Is the first generation antihistamine the culprit like diphenhydramine? Yes, there are no other culprit present here. My old theory, most of the time, if there is acute condition, acute psychosis, give them benzo, they will be all right. Benzo in any form, like mostly the IV form, and other form in in febrile seizure in babies, we give benzos too, like diazepam, per rectal diazepam. Yes, so it can be given per rectally also. Okay. Yes, in febrile seizure, drug of choice is this, like benzos, the diazepam. Okay. So this patient's agitated, restless behavior, insomnia, physical hyperreactivity in the setting of protracted period of intense studying are most likely due to stimulant intoxication, stimulant intoxication, misuse of stimulants, especially prescription stimulants for ADHD, is relatively common, with amphetamine style stimulants representing the second common illicitly used class of drug worldwide. Uh, group a high risk group is students. um, Stimulant intoxication. A high risk group is students, as in high school student preparing for final examination. Misuse is particularly prevalent on the college campuses when value being students value being able to remain awake and alert for extended study hours. Manifestation of sympathetic hyperactivity, hypertension, tachycardia, diaphoresis, hypothermia, mydriasis are characteristics. Psychiatric symptoms include anxiety, irritability, agitation, and in some In severe cases, paranoid psychosis, cardiac arrhythmia, movement disorder, and seizures can occur in overdose. In addition to supportive measures, benzodiazepine lorazepam are considered first-line therapy to control the psychomotor agitation and sympathetic hyperactivity caused by acute stimulant intoxication. With methamphetamine intoxication, benzodiazepine blunt CNS catecholamine release with improvement in the blood pressure, heart rate, and hyperthermia. Okay. Eight days ago, one incident happened, like more than 3 days, less than 1 month, acute stress. Is there anything? No, no, we are finding differential. Like acute stress is one of the differential because 8 days ago something bad happened to him, like his father died in a car accident. So it's a very traumatic or stressful situation. PTSD, if this continues for more than 1 month, then we can consider it as PTSD. Yes, and adjustment is like more than less than 3 months, but like within 3 months, the adjustment should be within 3 months. Yes, there is no adjustment here. It is not schizophreniform. It is, yes, it is not a normal grief. Yes, manic is 1 week of manic. Yes, yes. There is no psychosis, is there? Oh, okay. And it is not persistent complex bereavement. Can you explain what is this? The persistent complex bereavement. Oh, okay. Think about in your way. What you think? As brief psychotic may be the answer. Okay, it is very tough for me. You are right. Okay. So these patients acute onset disorganized bizarre behavior, keeping lights off and closing eyes, covering ears, and disorganized speech, nonsensical responses, and probable hallucination, whispering to himself in the dark, and whispering himself in the dark following the traumatic death of his father is consistent with brief psychotic disorder. A brief psychotic disorder characterized by psychotic symptoms lasting between 1 day and 1 month. As in this case, it is often triggered by traumatic or stressful event and can be specified with marked stressor. When triggered by the loss of the loved one, BPD should be differentiated from the normal grief reaction. In normal grief reaction, the individuals have hallucinatory experience that are centered on maintaining connection with the deceased. Their behavior and speech, however, are not disorganized and they are still able to relate with others. In contrast, this patient's behavior is bizarre and his responses on examination is nonsensical. Okay, next. Yes, yes. Acute stress disorder is characterized by intrusive re-experiencing of the traumatic event, accompanied by symptoms of hyperarousal, dissociation, and avoidance lasting less than 1 month. Yes. Okay. So patient related trauma will happen in acute stress, not the patient's attendance. Okay. So okay. Not like okay. Yes. What does he has? Okay. Yes. Okay. Grimacing. This patient facial grimacing combined with foot tapping, facial grimacing, and slow inversion and facial grimacing combined with foot tapping and inversion movement are most likely signs of tardive dyskinesia. Tardive dyskinesia caused by exposure to risperidone, a second-generation antipsychotic drug used in the treatment of bipolar and psychotic disorder, although most commonly associated with first-generation antipsychotic and antiemetic metoclopramide. Tardive dyskinesia may also occur with some SGA. What is SGA? Okay, okay. The risk of tardive dyskinesia varies significantly within the second generation antipsychotic class. Risperidone is among the highest risk of SGS, whereas clozapine and quetiapine are the lowest risk of SGS. Patients receiving a maintenance antipsychotic medication should be assessed for tardive dyskinesia at regular interval. Causative medication tapered or and discontinued. Causative medication tapered and discontinued if feasible. The patient has been stable and no recurrent mood episode for 3 years and may not require maintenance risperidone because lithium may adequately control her symptoms. Therefore, a reduction of discontinuation is feasible. Therefore, a gradual taper and discontinuation of the risperidone is the most appropriate uh, initial management. When the psychotic dose reduction and the discontinuation is not feasible, treatment option includes switching a lower risk agent clozapine and treatment with a VMAT, vesicomonoamine transporter 2 inhibitor, valbenazine, deutetrabenazine. Okay, next is is he? Yes. Is it generalized anxiety? Yeah. He will say something stupid. He is only in worry. Okay. He has social anxiety, social phobia. Okay. I don't know. I thought I got idea from your clue. No, no. You were right. I was confused with the GAD. Still, I am in the mystery of GAD. Okay. Generalized anxiety disorder. Okay. The patient's extreme anxiety in social situation and fears of scrutiny and negative evaluation are consistent with the social anxiety disorder. These patients' fear of saying something embarrassing and his anticipatory anxiety about interacting with co-workers and meeting with new people for both work related and social are characteristics of this disorder. His refusal of a job, social anxiety with an alcohol is a common complication of this disorder. Self-medication of social anxiety with an alcohol is a common complication of the disorder. SSRI and SNRI are the first line medication for SAD. CBT is considered for first line non-pharmacological. Okay, can we? Yes, buspirone and anti-anxiety medication and anti-anxiety medication that targets the serotonin receptor and indicating for treatment of GAD, not SAD. Patients with GAD have a chronic anxiety surrounding the multiple issue work, finance, safety, rather than anxiety exclusively focused on social interaction as seen in this patient. Okay, can we take a break? Yes. Okay.